Hello to all the Waldenstromers. I am super glad that all of you are here, and I give a great thanks to all who have sent in questions for this forum. Unfortunately, there are too many to ask all of them, but we will do our best of this extremely good panel. All of our panelists today are worldwide known and are chomping at their jaws to answer the mysteries of Waldenstrom that we all want to hear. We have Dr. Stephen Treon at Dana-Farber, Dr. Stephen Ansell at Mayo Clinic, Dr. Jorge Castillo at Dana-Farber, Dr. Christian Buske at University of Ulm in Germany, who is an oncologist and a worldwide researcher, Dr. Mary McMaster, who we just listened to an hour ago or so, who is a cancer epidemiologist and genetics researcher, and Dr. Andrew Branagan at Massachusetts Hospital and Yale University, and we're increasingly hear more about his work as he grows into this. I am going to have to give a disclaimer to the audience, and the disclaimer is that the doctors on this panel are going to educate us on many things that we live with every day with Waldenstrom. You have to understand, though, that they're not giving you medical advice. That is unethical for them. You should discuss these things with your personal doctor if you're interested in some of the things that our panel has told you. So I guess it's time to go to the first question now. And the first couple of questions are about BTKI inhibitors, which is ibrutinib and such as that. Now that zanubrutinib has been FDA approved, do you have a preference between ibrutinib or zanubrutinib? Anybody want to spec that up? Dr. Treon?
Thanks, Tom. I think, fundamentally, this is probably the most important or most interesting question, that we'll encounter today. And it will be very interesting to see how other panelists also think about this. As a field, I think we should be very excited that we now have yet another BTK inhibitor that's approved by the FDA, and soon, I hope, by the EMA in Europe. And we do know from the data that was generated from a randomized trial that, there are clear pluses to zanubrutinib in terms of tolerability. But I do think, at the end of the day, we have to be clinicians and weigh these choices based on a number of factors, which include convenience, daily administration, once daily with ibrutinib versus twice daily with the zanubrutinib. Some issues around, experience that we have, long-term experience, which is with ibrutinib, I think very relevant when you start thinking about, certain morbidities associated with Waldenstrom's, including getting into the brain and treating Bing-Neal syndrome, when patients encounter that, or wanting a deeper response, which you might see with zanubrutinib. But I think also the tolerability is very important. Zanubrutinib profile looked far more positive when you think about things like atrial fibrillation and bleeding risk. But on the other hand, there was also, more events of neutropenia. So when you have somebody who you might think might be at risk for atrial fibrillation, you might want to prioritize zanubrutinib, given the overwhelmingly positive data there. On the other hand, if somebody's, blood counts are, really low, you might want to think about ibrutinib because we did see those cytopenias. So I think to all the audience, this is going to come down to individual patient considerations, and I'm very curious to see what our other doctor panel members think.
Dr. Castillo?
Yeah, I think it's an unanswered question at this time in terms of having an actual preference. When we looked at efficacy, really there were no major differences in terms of efficacy between zanubrutinib and ibrutinib. And again, both treatments should be taken indefinitely until disease progression or unacceptable toxicity. We do have longer term data with ibrutinib, right? We have over 9 years of experience with ibrutinib. The first clinical trial that was run by Steve started in 2012. So we have a handful of patients who are still going really strong, 2021, 9 years out, taking ibrutinib from that initial study. So that's very important to review. So I think it is a balance and a number of trade-offs that we need to look into, the AFib risk versus the neutropenia risk, the once-a-day medication, versus the twice-a-day medication, or the long-term data. So I think is more of a conversation and a personalization of, in order to make that decision.
Dr. Ansell?
Just think that both the other physicians summarized things well. I guess I just wanted to make one point, and that is that we really have two very effective therapies and two very well-tolerated therapies. So in some respects, it's good and great. It's not a case of like there's a dramatic difference here. And if you actually were to say, what's the likelihood of some of these toxicities and side effects? In general, 8 to 9 out of 10 people are going to take the agents and tolerate it just fine. 9 out of 10 probably without atrial fibrillation, regardless of which agent one takes. So I do think that as we're thinking about the side effects, Dr. Treon was right on. The patient's sort of personal profile of where they are in their disease and their symptoms and their other potential problems they may have are critical. But I don't want people to get the misconception that these are hazardous and there's a big dramatic difference. These are really very modest differences, and as Dr. Castillo said, very important to see that the efficacy is very, very similar.
Okay. We're ready to go to the next one. Next slide. If someone has been taking ibrutinib for 3 years and all of the numbers are now stable, why not reduce the dosage? Have there been any studies that show reductions delay in the inevitable resistance to ibrutinib by lowering the dose? Dr. Castillo?
Yeah, so this is something that we have been investigating. Now, I want to be very clear about this. We have some experience in dose reductions with ibrutinib. This actually is an abstract that we are presented at ASH this year, presented by our colleague, Dr. Shena Saroshek. And I think the bottom line of that specific report is that we sometimes have to decrease the dose in patients with receiving ibrutinib for many different reasons. It could be rashes, it could be diarrheas, it could be some other problems. And that happens probably in about 20 to 25% of the patients. Now, the dose reductions in those patients were driven by toxicity. They were not driven by how effective the medication was being for these patients. So we need to understand that if somebody is having stable numbers, great numbers, good numbers on ibrutinib, if the patients are not having a toxicity, I don't think it's clear what the benefit is on decreasing the dose in that specific scenario. Having said all that, if a patient is having a great response and they're having toxicity from the medication that is affecting their patient's activities of the daily living or the quality of life, at that moment, we could potentially reduce the dose. And in this study, we have been able to show that if we go from 420 to 280, there's at least 2 to 3 years of stability in which patients, actually some of the patients even deepen the response a little bit more, even though the dose has been decreased. But again, all this is retrospective data. This is not prospective data. There had not been a formal study comparing 280 versus 420 milligrams of ibrutinib. So, for us to, I think it has to be more of a personalized decision driven by toxicity rather than the efficacy of the drug.
Dr. Buske?
No, I'm the German perspective, but it's very similar. So we never reduce without any necessity. So it's really driven by toxicity. It's a little bit also the experience in chronic lymphocytic leukemia, where we have data when we do dose reduction, in particular in the first year, that we might lose also efficacy. So I think what Dr. Castillo said, I can just confirm. So when everything is fine and you tolerate the drug well and the disease is controlled, don't change a winning team.
Dr. Treon? Tom, a question came up in the chat box, which I think is also relevant. And that is, what do you do with somebody who's not tolerating therapy? Do you have the ability to switch over to another BTK inhibitor? And we now have data on this. We know that a switch over from ibrutinib when patients aren't tolerating it to acalabrutinib is feasible. We know this from CLL data. But we also now have data with a zanubrutinib switchover. In fact, Dr. Shadman presented a very nice study at EHA, the European Hematology Association meeting, and in fact showed that in 75% of the cases where somebody had a side effect, including atrial fibrillation associated with ibrutinib, that they could be successfully switched over to zanubrutinib and not have that side effect. So, as we're thinking broader about the use of these BTK inhibitors, I think we're blessed in the sense by having more that even if somebody encounters a side effect, we have the ability now to also switch over the patient. And shy of that, I would not advocate for, decreasing somebody's dose or making a shift to another BTK inhibitor unless there were really genuinely, solid reasons why we have to do so.
Okay. The next question is the very same question, but now it's a patient with Bing-Neal syndrome taking 560 who wants to lower their dosage. Do you give the same thing to this answer? This question, I mean. Dr. Ansell.
Bottom line, don't. Bing-Neal syndrome especially, I would be very, very, concerned about because it's all about getting enough drug into the brain space. And, from our own studies, because we studied this, we simultaneously looked at blood levels and levels of drug, in this case, ibrutinib, in the cerebral spinal fluid. And, just shy of around 3% of the drug actually makes its way through. And so you really, if you're having control on this dose, and you're tolerating it, I wouldn't tempt fate in this case. I would continue with the same dose.
I'm just agreeing completely with Steve on this one. I think a few things from this particular person that are notable. 6 years with the Bing-Neal and doing well on ibrutinib, that's a huge thing, and that's great. I think important to know we need to push the dose, and so dropping the dose back may drop the efficacy back. And I would also, again, we touched on this before, but I just think it bears reminding people, the toxicity you don't have when you've been on the drug for 6 years is not necessarily one you're going to get. So if you've been on a drug and you're doing well and you haven't had particular problems with bleeding or atrial fibrillation, it doesn't mean that's immediately around the corner. You might not be liable to get that. So don't be mucking with the treatment dosing for something you don't have. And interestingly, even when you do have it, we can work around atrial fibrillation and other things if the benefit in a serious circumstance like this is great enough. And so if you're doing well, we would rather you stay on the drug and continue to do well, and we'll work out how to handle the atrial fibrillation than make a change and suddenly find you're in real trouble from your disease. I know Dr. Buske was going to say something.
No, I can just confirm. So because Bing-Neal is a serious condition, and I think it's a great situation you are in, and we don't have any experience with alternatives such as ibrutinib. It's too early. Perhaps in many years we will have these data, but at the moment they are not existing. So I would also urgently advise to stay on the drug with this dose.
Great. Excuse me. The next question, please. Do you expect that third-generation reversible BTK inhibitors like pirtobrutinib will be less likely to lead to resistance than the irreversible ones? If so, should we switch to a reversible one at the earliest opportunity, or if the irreversible one they are on has stopped working or become intolerable? Dr. Treon?
No, should not.
You're bringing up, Tom, a lot of good points, with this question. I think it's important for the audience to understand that there are two classes of BTK inhibitors. One is the covalent ones, like ibrutinib, acalabrutinib, and zanubrutinib, that when they bind to Bruton's tyrosine kinase, that bond is a very strong and nearly irreversible bond. But when you're talking about non-covalent BTK inhibitors, the word non-covalent means that, that bond isn't very strong and it's very much concentration dependent. So you're not going to have the same kind of characteristics in terms of suppression of BTK function. And you'll always be at the mercy of the levels of drug, that are available. And that's why, from a preference point of view, covalents are likely to be our first, choice in terms of the therapy of all the diseases now that we see BTK inhibitors in. And it's really in the setting where somebody might be progressing on a covalent BTK inhibitor that it makes sense to think about a non-covalent one, because the binding site is very different than the binding site for the covalent ones. So all the covalent ones bind to the cysteine amino acid on position 481 of the amino acid 481 on Bruton's tyrosine kinase. The non-covalent ones bind at a different, locus. And that's why, we have the ability to treat somebody who's progressing, who's acquired that mutation in the cysteine 481. It's the most common mutation that we've discovered in patients that are progressing on ibrutinib. And that's why you want to think about non-covalence in that particular scenario.
Dr. Buske?
And also another very simple argument is the data on Longso are quite limited for Waldenstrom. I think it's still very early, in particular for Waldenstrom, so we have more data on CLL and mantle cell lymphoma. But in Waldenstrom, it's really very limited still, and I think we need more experience, more data to have the courage, again, to change a winning team and a drug which works that well as the covalent inhibitors.
Dr. Castillo?
Yeah, I agree. And that's why I think the studies need to be done specifically in patients with Waldenstrom's and with the specific criteria. Now, I don't think we will feel too comfortable switching a patient who's doing well in any of these covalent inhibitors into pirtobrutinib, but rather those patients who are having severe toxicities and patients who are not responding to these agents anymore. I think that's a population of patients that we are going to include in clinical trials.
Super. Go to the next question now. Is there any long-term follow-up of patients taking BTKI inhibitors to monitor for side effects? Does the research data to date indicate any long-term effects on the bone marrow or other body systems affected by the inhibitors?
Tom, I'm not really making sense of the question. Can you repeat it again?
I think what they meant is, do we have really long enough data on BTK inhibitors to understand if there's any further toxicity with longer use? And I think, as I said earlier, we have about 9 years of follow-up in patients with Waldenstrom's taking ibrutinib, and we have not seen really, a lot of unexpected toxicity besides of what we saw in the first years, and that was seen in the frontline relapse and the ibrutinib rituximab data. Really, we have not seen any unexpected toxicity, with longer follow-up. I think that's what the question is referring to.
Dr. Buske?
And I think what perhaps also is a little bit implied into the question, so we also don't know any irreversible side effects, meaning that these BTK inhibitors actually cause anything which is persisting when we stop them. Of course, what we know since COVID even better is the immune system, of course, is depressed. So I think this is a side effect, which is for sure relevant. Yeah, but we know this from many other drugs, of course, also. So it has side effects, but for instance, as I said, with regard to immunosuppression, but otherwise, I don't see anything which is close to bone marrow, let's say, or bone marrow cells, if you want so.
Okay. Okay, let's don't change the next question because I'm going to add one that we don't have a slide for. And this is for Dr. McMaster. Dr. McMaster, do people with Jewish descendants have a higher percentage of familial diagnoses than others?
Thank you, Tom. So it depends in part, I think, on where you look. Dr. Treon's group up at Dana-Farber has found an excess number of Waldenstrom's patients among the Ashkenazi Jewish community than one would expect, given their representation in the general population. What we don't have are population-based studies that control for geography. So if you look at census data, the Jewish population is concentrated along the Atlantic seaboard, really from the mid-Atlantic up to through the Northeast, and not so much in the center of the country. And so we don't have good data across populations to be able to say with certainty that that's the case. But where institutions that are tertiary, that are collecting patients from the surrounding area have looked at this, they are seeing an overrepresentation amongst the Ashkenazi.
Okay, thank you, Dr. McMaster.
Mm-hmm.
We can go to the next question now. Next slide. The question is, there it is, a recent study of multiple myeloma patients suggests that T-cell response to COVID vaccination is significantly impaired in those who have had poor antibody response to vaccination. Have you seen any data suggesting whether this is also true of Waldenstrom patients?
Yes.
Dr. Branagan?
Sure, thanks, Tom. So this is a great question, and I think COVID is on all of our minds. And that there's actually been a couple studies showing this in myeloma, that T-cell responses are impaired in addition to antibody responses. And I think it's probably a good time to just pause and think through the difference between antibody and T-cell responses. So the primary goal of the vaccine is to make antibody responses against a certain protein on the outside of COVID-19. So you can actually neutralize an infection before you get it. But this is not always the case, and people still end up getting infections. And part of a response to a vaccine is also a T-cell response. T-cell responses tend to be more cross-reactive. And so if the virus mutates and you can't neutralize it, you can still fight that off to some degree. And in fact, there was a great study that really showed the importance of T-cell responses in Nature Medicine recently, looking at 100 cancer patients. And sure enough, patients with hematologic malignancies had a lower amount of antibody responses, as we've seen from many studies, including this one that's hinted at here. But in fact, the majority of patients were still able to have a T-cell response. So that was very, I think, reassuring, especially for the patients without an antibody response. And the other important piece that how important this was, those patients that got sick with blood cancers, including Waldenstrom's, one of the most important factors for those who survived are they had a certain type of T cells that were reactive to COVID-19, and those were CD8 T cells. So many of these studies so far don't really know which type of T cells were reactive to COVID. And I think that's something that more research is needed. We are doing a study at Mass General and at Dana-Farber, and we're collecting T cell studies, and we're going to have some more information shortly to add to this. The initial findings are that even patients without an antibody response, we are seeing some T cell responses. That is something I can say at this time.
That's great to hear. Dr. Ansell?
I think all of those points are really important. I think two things I would just add to that. One is just remember that some of the therapies that are given for multiple myeloma and some of the therapies that are given for Waldenstrom's are different. And importantly is that patients may have different immune responses and different effects on their immune response based on the treatment they may have recently received or be receiving. So I just think that's a little differentiation that needs to come in. And then really just to pick up on what Dr. Branagan was saying about the different types of immunity, there's even one further immunity that we really don't understand particularly well at all, and that's called mucosal immunity. And that's actually the cells that are in your snot and other kind of parts of your upper respiratory area, which can also help, and some of the actual natural physical barriers that exist there too. So all of those are factors that help you with fighting off various infections, including COVID-19.
Great. Those are great answers. Dr. Buske?
Just as a short remark, this is also the rationale why we recommended, in particular in the very beginning, but also even now when the situation is like this, vaccination upon treatment. Even upon B-cell depleting treatment, vaccination can make sense because of this T-cell response.
That's super. That's super. Okay, let's go to the next question then. Please address Waldenstrom wild type. Is it Waldenstrom or is it marginal zone? To which current treatments will it best respond? Dr. Treon?
Yeah, happy to take this one, Tom. So just for the audience's sake, when you think about wild type, what they're referring to here is that the patient does not have the MYD88 mutation. What we do know is that many of these patients tend to have other mutations that are in the same pathway as what MYD88 can generate. And many of these mutations also overlap with what we see in different aggressive lymphomas. So this is why the patients that have no MYD88 mutations that genuinely have Waldenstrom's tend to be at a higher risk of transforming to a more aggressive lymphoma. So that's important to keep in mind. What we also know, though, is when we look at the characteristics of these patients, they genuinely overlap with those patients that have the MYD88 mutation. It's very hard to distinguish them when you look at the bone marrow. When you look at the level of IgM that they have, it's very hard to distinguish. They do, however, tend to have cells that are slightly different. They're more B-cell-like as opposed to plasma cell-like. So B-cell-like meaning more like a lymphoma as opposed to a plasma cell-like that's more like a myeloma. So we do know that this difference does exist. We have now data that zanubrutinib is effective in this population. Traditionally, we've used either bendamustine or one of the proteasome inhibitors like bortezomib to treat the patients that are MYD88 wild type. The one last thing I'd like to say is it's important that testing be done correctly. PCR testing tends to be more accurate than using next generation sequencing. So sometimes you can have people that are, falsely labeled as not having the MYD88 mutation because of the testing platform that was used.
Anybody else? Okay, we can go to talk about some rituxan now. Next question. If you are vaccinated for COVID and then take rituxan, do you lose your COVID immunity?
You don't.
Dr. Buske?
You don't. So very simple, because it's not affecting your memory B cells and plasma cells. So this is the good part. So when you have built up your immunity, and this is why we are also recommending to do vaccination before you start B-cell depletion with rituximab, not only in Waldenstrom, but also in other B-cell lymphomas, it's feasible.
Dr. Branagan?
A great point, Dr. Buske. And I think we should clarify this question because I think we are assuming this meant you're fully vaccinated and that vaccine has taken effect, because that does take at least 2 weeks from the final dose of a series. And as you know, that's how many doses you get is constantly evolving, whether it's 3 or if you need boosters. So it's true you won't lose your past immunity, but future immunity will likely be impaired. So growing studies, both with lymphoma, CLL, and our study with Waldenstrom show if you are, within 6 months or less of rituxan, you do have a hampered antibody response to rituxan.
No, that's true. So what I meant is really when you have built up and then you start. But of course, when you are vaccinated, then upon treatment, you have to have the problems and a long time after this.
All right, next question. Dr. Branagan, you may have already answered this next question. If we can go to it. When your B cells repopulate after Rituxan, does a pre-Rituxan COVID vaccine-induced immunity return? And change the slide, please.
I think we can't see the slide.
No, it's the one before that, I'm sorry. There.
That's right. This is, I think, what I already answered, but if anyone else has something to add.
Okay, yeah, that's what I thought. Okay, do you need to be revaccinated for COVID, Shingrix, tetanus, etc., after taking Rituxan?
No.
Difficult question, I know.
So I could maybe take it, and others I'm sure will comment, because I think all of us kind of are working through some of this. You know, before COVID, we did not routinely re-immunize everybody against everything when we gave them rituximab. And we didn't see a lot of tetanus issues. Even shingles, although one can certainly get it, often was more related to the chemo part than to the rituximab part of therapies that were given. So I think based on that information, the only time that we really kind of did re-immunizations is when we did very intensive therapies like stem cell transplantation or CAR-T cell therapy. So I think we have to extrapolate that information mostly to what our answer here would be, and that is to say no, because we don't have any evidence to say that revaccination, one, is necessary, and two, is effective if your immune system is compromised.
All right, that sounds good. Let's go on to the next question, please. We skipped one. The one that we skipped is subcutaneous Rituxan, Hicella, okay to replace Rituxan infusions? The one that's up here is not there yet. Go back a slide. No. Keep going. Keep going.
So you mean that sub-Q can substitute IV?
Yes. Is the subcutaneous Rituxan as good as the intravenous Rituxan?
I mean, there's some data, right, on follicular lymphoma and diffuse large B-cell lymphoma, kind of comparing both compounds, and they have shown to be, very similar. There is very little data on Waldenstrom. There is a study in which ixazomib, dexamethasone, and subcutaneous rituximab was used. This is the Dutch study, which still should be coming out shortly, showing that it's feasible and reasonable. So the NCCN guidelines have actually added the use of subcutaneous rituximab as a possibility for patients with Waldenstrom's who tolerated the first intravenous infusion, like we do it with other lymphomas. My sense is we can use it. I have used it in my practice, and it is a possibility.
Dr. Buske.
Yeah, I think we have very solid data in follicular lymphoma, also pharmacokinetic data, and we have run a large Waldenstrom study with over 200 patients in Europe with rituximab sub-Q, and are at the moment also having a trial with rituximab sub-Q and ibrutinib and bortezomib sub-Q. So it works nicely. It's very feasible, and we don't see any signal of concern.
Okay, let's go to the next question then, which is already up there. My 3-year BDR remission ended with a crash about 2 weeks after my second Pfizer vaccine dose. Have there been any other similar reports concerning vaccine interactions with Waldenstrom remissions? Dr. Treon?
Tom, it's very hard to to link these two events together, and they could be true, but unrelated. But in past years, we did see that in some patients that their IgM levels could spike after getting a flu vaccine. And we do know from experiments that were done in our laboratory that when we took Waldenstrom cells and we stimulated them, much like the kind of stimuli that we use in vaccines, that we could trigger the MYD88 pathway. But this didn't really, as far as I know, didn't really cause a progression in disease. We saw this mere spike up in IgM, and then the IgM returning back to normal in a small handful of patients over the years. So I just think it was important to offer that observation, but it's hard to say and link these two events as is the case here.
Okay, yeah, I agree with that. Dr. McMaster, do the younger familial patients, sons and daughters, normally be diagnosed earlier than their Waldenstrom parents? I was diagnosed at age 50. My father was diagnosed 2 years later at an age of 72.
So thank you for that question. That's been an important one in the field for a number of years. And there certainly, in terms of absolute age at diagnosis, we see that second cases in families tend to be diagnosed earlier than the first case. But it seems that is largely related to the fact that we know that, and people are about the diagnosis in the family, and people are hypervigilant and are going to their doctor sooner or being screened. And so there doesn't appear, when this is a phenomenon that we call anticipation. And when it has been looked at very rigorously, it tends to go away. Now, having said that, young age at onset is a hallmark of familial disease, but that doesn't mean that every patient will be diagnosed at an early age. But when we see very young people diagnosed with Waldenstrom's, we start thinking familial and pay much more attention.
Thank you, Dr. McMaster. Dr. Treon?
As I recall, when we did our study, Mary, looking for the familial incidence of Waldenstrom's, that I think we had about 250 consecutive patients at the time that we looked at. Roughly 20% had a first or second degree relative with either Waldenstrom's or another lymphoma. But as I recall, those patients that had familial disease were diagnosed almost a decade earlier than the ones that had non-familiarity. And these were, again, consecutive individuals. Of course, anticipation is something that we always encounter because family members are keen to know whether or not they may be at risk for disease. But I think that's a very interesting observation to see that potentially these people may be at an earlier risk of acquiring Waldenstrom's.
Yes, and I would agree with that entirely. And I apologize if I wasn't clear. The familial Waldenstrom's patients do tend to be diagnosed considerably earlier than non-familial patients. But what we don't see in a reliable, reproducible way is that generation 1 is diagnosed late, generation 2 is diagnosed earlier, generation 3 is diagnosed even earlier. That has not held up.
Okay, let's see if we can get the slides moved up to the slide that starts as, yeah, there it is. Okay. These are a couple of CAR-T test questions now. Do you first foresee CAR-T gathering any steam for lymphomas and specifically for Waldenstrom's? Dr. Ansell.
So I think we can safely say in the world of lymphomas that CAR-T cell has already gained a significant head of steam. And the reason for that is just there are randomized comparisons in relapse patients right now in large cell lymphomas soon to be reported, comparing that against stem cell transplantation. There's now use of CAR-T cells standardly in patients that have failed treatment with mantle cell lymphoma and with follicular lymphoma. So certainly, as I say, this is a highly successful therapy. And I think in Waldenstrom's, there's going to be a subset of patients where this could be very relevant. The challenge is just the side effect profile is substantially greater than some of the other agents that we use. So one would need to be quite selective in who you actually treat. But certainly, if some of the longer term follow-up shows that patients are being cured with this strategy, that may completely change how we think about using it.
All right. Anybody else? The next question, next slide. Would there be any particular advantage or disadvantage to using CAR-T therapy instead of stem cell transplant in Waldenstrom?
If others go, Dr. Castillo.
Yeah, no, I think it's a very, we can make this answer really short or really long. I think that the shorter side of things is, I think we need to see, we need to design the studies. We need to see how CAR-T cell therapies do in patients with Waldenstrom's, and then we can actually, make a more intelligent assessment if, is preferred or not preferred over stem cell transplant. I think we'll learn a lot of what is being done currently for other types of lymphomas. I think the second issue for Waldenstrom's in terms of CAR-T cells is which product to use, right? Do we need to use a CD19 directed product or a BCMA directed product, or maybe a bispecific product, or maybe one of the new off-the-shelf CAR-T cells? I mean, the technologies keep advancing so rapidly that, I think we will see probably, hopefully, a generation of CAR-T cell products that have much less toxicity. And we will decide then what type of product we should use. I think there should be a future for CAR-T cell in patients with Waldenstrom's.
I guess I would just make the one point, though, that stem cell transplantation is being used less frequently in Waldenstrom's maybe than we did before, partially because of all these other treatments we spoke about that have been highly effective. So I do think that this CAR-T cell autologous transplant population is a population that's kind of way down the road as far as when you utilize it and how many people need it.
Dr. Treon.
Tom, the only other thing, I think those are all great answers that were given by both Jorge and Steve. I just also think it's important for the audience to know that there's also this new class of drugs called bispecific antibodies. And these also look very, very promising and potentially may give us, similar levels of response as what we're seeing with CAR-T cell therapy, but perhaps being less cumbersome to be able to deliver this therapy, because by the time you make the CARs, sometimes, patient's disease has progressed, whereas bispecifics you can administer to the patient. And what they do is they actually bring the immune cells in contact with the tumor cell. And so, it would be an off-the-shelf thing as opposed to having to construct somebody's CAR-Ts.
All right. You can tell by this next question, which we can go to, that this person is deep into Waldenstrom research. To your knowledge, is anyone looking at BCMA targeted or bispecific CD19 and CD20 targeted CAR-T therapy for Waldenstrom? Dr. Castillo?
Yeah, so there are two programs in the country. I think one of them is looking at CD20. I think that's the Seattle group. And there's another group at UNC, the University of North Carolina, looking at a CD19 product. I'm not aware of BCMA product currently being used for Waldenstrom, but those are two ongoing clinical trials that could enroll patients with Waldenstrom's. It's not specific for Waldenstrom's.
Okay, next question. They get a little easier now. when I read articles, I always see a p-value reported. What is the significance of a p-value?
But that's not easy.
Castillo, this is right up your alley.
I know. A p-value is means probability. What's the probability of what we're seeing? Is actually a real finding, or it's just secondary to something being random. So obviously, the smaller the p-value, smaller the probability of that event is being seen. That means that it's more likely caused by our interventions. So there's a big movement of actually moving away from p-values in clinical trials, in clinical research, and get more into confidence intervals and try to understand where our true values might be in a range of values rather than giving a p-value. The idea of p-value, the problematic idea of the p-value is that a lot of people understand it as a yes or no answer. So yes, it works when it's less than 0.05, or no, it's completely useless when it's 0.051, right? And that is not absolutely correct. I mean, this is not what the p-value means. So it's a statistical value and needs to be interpreted very carefully. And us as investigators, sometimes we commit our own sins by giving it too much value to the p. And also journals are more likely to accept publications or studies that actually show a significance in the p-value and otherwise are considered negative if the p-value is not. So there's again, I could go on and on. Bottom line, we need to be careful about these p-values. They need to be interpreted in the right context, and we just cannot assume that it's a black or white answer.
Dr. Ansell?
Just on a lighter note, I think Mark Twain was the one who said there are lies, damn lies, and then there's statistics. So I'm not saying that, but I think Dr. Castillo is completely correct. The whole thing is it's a likelihood that it's complete garbage. The smaller the number, the better.
Yeah, the thing I've always disliked about the p numbers is that they say that 95% is truth, and that's what 0.05 means. So that means 5% aren't true, which is just like our COVID, which everybody is fussing about. And then there's also type 2 errors, but we can go into that later. All right, we can go to the next question, please. Dr. Buske, is your mouse model of, that was messed up. Can I go to the next slide, please? Another one, right there. No, that's not it. Dr. Buske, is your mouse model that you produced, is my thing really messed up. Is your mouse model showing you progress as far as working with Waldenstrom?
Oh, yeah, of course. So we are working on it. So it's not easy to actually generate mouse models for indolent lymphomas in general. It's a difficulty because in mice, the lymphomas always tend to become or to behave like an aggressive B-cell lymphoma. So what we did is that what we see is that with the mid-88, I think there are also data from the Boston group, that we see some subtle differences when we co-express CXCR4 mutations. What we see after quite long latency are development of B-cell lymphomas in part of the mice. But again, a part of these B-cell lymphomas are again aggressive. So I think this is the major difficulty, to really mimic this very smoldering, long indolent cause of Waldenstrom in mice in a robust way. So what we can mimic is some effect of the MYD88 mutation. What we can mimic is that adding CXCR4 mutations are changing the disease towards more penetrance and to more aggressiveness, but we don't have a robust model where we, let's say, have in the vast majority of mice really a human-like Waldenstrom's disease. I think this is very tough.
Okay. Don't change the slide because that's the next one. Assuming that safety and efficacy data in a phase 2 clinical trial of venetoclax in relapsed refractory Waldenstrom remains positive, do you have a sense about whether AbbVie will choose to seek FDA approval for single-agent venetoclax for a treatment of Waldenstrom patients?
I can take that question. So my sense is AbbVie might not go for FDA approval, but if the study shows the safety and efficacy that is expected, probably will be added to the NCCN guidelines.
Dr. Treon?
Tom, just to say, having been through this process with ibrutinib, when like Dr. Castillo's study on venetoclax was what we call investigator initiated, the level of evidence that the FDA wants to be able to have an approval process is much more rigorous. And this involves, for the most part, having a company that can actually take on the study and have the kind of monitoring and auditing, that's intense at a level that the FDA expects. When we did the ibrutinib trial, that was in fact investigator initiated by us, and it did lead to approval, but that's really the exception to the rule to see that kind of process take place. And it was really in the sense that there was no approved therapeutic in Waldenstrom's that really helped, convince the FDA of the data that we were able to present. But, this would be a very hard sell to the FDA, knowing that this was not, a study that was carried out with that kind of rigorousness. And that's why it's important, again, for our audience to understand, the levels of evidence that the FDA expects for these kinds of approvals.
Okay. Next question, please. Some Waldenstrom patients, along with other blood cancer patients, have participated in early clinical trials of next-generation PI3K inhibitors. These drugs have been approved for other blood cancers. However, they don't seem to be aggressively pursued in clinical trials designed for Waldenstrom patients. I'm thinking especially of Waldenstrom patients who have relapsed from other drugs, including BTKI inhibitors. Is the toxicity profile of these inhibitors unacceptable for Waldenstrom patients? Dr. Castillo?
So we were very intrigued by PI3 kinase inhibitors, based on the research, biological research done by Dr. Steven Treon's laboratory. And we actually wanted to conduct a clinical trial prospectively with idelalisib. This was a study that we did some years ago. And our goal was to include 30 patients, which is what the standard we were doing, at that time. Within 5 days, within 5 patients, we had 3 patients with severe liver toxicity. The liver function tests went really through the roof, and we had to stop all these medications on all these patients. So after 5 patients, of which 3 of them had severe liver toxicity, we decided to stop that specific therapy. There's an ongoing study with umbralisib, which is, they're still analyzing the data. I know umbralisib just got approved for follicular lymphoma and marginal zone lymphoma based on that study, but they have not yet reported the data on Waldenstrom patients, and there's some experience there, so I'm still waiting to see what those data will show. And there's another study from France in which idelalisib was combined with obinutuzumab, and they were able to complete the study, but there were a lot of liver toxicity and other immune-mediated toxicities as well. So based on the lower efficacy and the relatively short progression-free survival and the higher toxicity, at this time, PI3 kinase inhibitors are not part of what we tend to do routinely for patients with Waldenstrom's.
Thank you, Dr. Castillo. The next question, if someone is taking 240 milligrams of ibrutinib and somebody else is taking 420, can you say who might develop resistance first? 3 no's.
No, you cannot.
No?
No, you cannot. There's no correlation between the dose and the development of resistance. So it's no close correlation. So I don't know, perhaps Steve knows more, but I think it's very tough to understand why one patient develops resistance and the other not.
Yeah. You know, Christian, I was very impressed when we looked at the BTK CIS481 mutation, the most common mutation that we see associated with ibrutinib resistance. And what impressed us was it was those patients that had the CXCR4 mutation that were more likely to develop the BTK CIS481 mutation. So I think it may really the answer may lie in the genomics. Tom, it seems like we might, just looking at the chat here, we may have, created a discussion that I think, is important to settle on, going back to the venetoclax question, and really important for the audience that many drugs, even though they're not specifically approved for Waldenstrom, still make compendia, like the NCCN guidelines, and then prescribers can actually prescribe them, and the NCCN guideline is actually followed by many insurers, including Medicare in the United States. So, that would be the mechanism under which one can access those drugs. So it's really important for people to realize that even though a drug isn't specifically approved for Waldenstrom's, this is the mechanism that's often used to be able to get, access to that drug.
Okay, great. Next slide, please. Dr. McMaster, I know in your talk earlier that you discussed Agent Orange and Waldenstrom, but some of the people here may not have heard that. So do you have anything else you can add to, is there a linkage from exposure to Agent Orange and Waldenstrom?
So this is a difficult question to answer. There are not much in the way of published data that look at Agent Orange and Waldenstrom's. However, the government has made a ruling that provides compensation to veterans who have developed Waldenstrom's and have a history of Agent Orange exposure during their service. So the VA and the Department of Defense, they don't make these determinations lightly, but all of the data that went into that decision, not all of it is available for review.
Thank you.
So in the eyes of the US government, yes, there's a linkage.
All right, thank you very much. The next question, I apologize, I didn't look this drug up. Perhaps somebody knows about it, but do you think all Waldenstrom patients should get AZD7442 when or if it is approved, since none of us know if the COVID vaccines are effective for Waldenstrom patients? Is anybody aware of that? I guess we can go on, and if somebody thinks we can come back.
Yeah, we have no data, Tom, so I don't think we can offer any guidance.
No, okay, all right. Are there studies or genomics that show difference between men and women in terms of diagnosis, symptoms, and treatment of Waldenstrom?
Looking at the key mutations so far with MYD88 and CXCR4, we have not seen any underlying differences in terms of MYD88 expression between men and women, and the same is also true with CXCR4.
Okay, Dr. Ansell.
Just a comment I made with one of the talks yesterday. There is some data for lymphoma in patients receiving rituximab that women and men may metabolize it differently, and so the doses may be a little bit different. But aside from that, I'm not aware of anything else.
All right.
Agree.
Next question. Please explain the reason there is a problem with blood clotting while taking BTKI. Any thoughts on that? It's difficult to figure that out.
Yeah, so I mean, I think the main issue with BTKIs is the risk of bleeding. It says problem with blood clotting, but what we see is actually bleeding. We don't see clotting with BTK inhibitors, except when we're talking about AFib, and that's a different scenario. So what we tend to see is bruising. We tend to see an increased risk of bleeding with procedures. And the reason for that is because BTKIs affect how the platelets kind of clump together. There are two processes in which this happens. The platelets actually form an initial layer of protection, and that is called adhesion. And then the platelets are kind of form different layers to form the clot, and that is aggregation. So both processes, the adhesion and the aggregation, are actually affected by BTK inhibitors. It's similar to what happens with aspirin. Yeah. So the recommendation that we provide to patients is, depending on how invasive any procedure is going to be, either biopsies, tooth extraction, surgeries, endoscopies, then the patient should be off ibrutinib or BTK inhibitors for a few days before and after to minimize the risk. But that's the explanation for it.
Yeah, that's what I thought about the question, is that the blood clotting was in general and they meant bleeding, but maybe not. All right, let's go on to the next one. With the advent of safer treatments, do you foresee treating watch and wait patients earlier? Will the threshold for initiating treatment drop? Dr. Buske.
I would be very cautious with this. So, of course, it's attractive, let's say, to treat earlier, but I think we have no evidence that our watch and wait strategy is as standard is in some way changed by this new drugs. So there's a large trial in Germany with regard to chronic lymphocytic leukemia to do watch and wait versus ibrutinib. And the data is still not out, but it looks not good. So I would be very cautious in changing our standard just because we have well-tolerated and effective drugs. But it's a very important topic. And it's a question whether we ever will have a good clinical trial testing this. But at the moment, I would not do anything, would not change anything.
Yeah, it's difficult to give people medicine that aren't having problems. Dr. Ansell.
So I think that's really the key question and the key issue, Tom. I mean, I think one of the things you have to say is when you treat earlier, what is the goal? So there are a few reasons to treat earlier that make all the sense in the world. If you have a treatment that can cure a disease, treating earlier makes all the sense in the world because you want to get rid of the disease for sure. Unfortunately, in Waldenstrom's, we have very effective therapy, but we don't know that it's curative therapy. So I think that's one thing to remember. The second thing is, if we intervened early, would people live longer? And again, we have data from other lymphomas where that doesn't appear to be true either. And then the third question is, well, if we treat earlier, would we make people feel better and prevent complications and side effects like we prevent in myeloma and other diseases? And the point is that clearly if we don't allow the protein to end up so high that you get hyperviscosity problems, that doesn't seem to be true in Waldenstrom's either. So I think one has to be very careful about taking a treatment that, as we're discussing, potentially has its own effects, which could be side effects, too early and actually just generate more problems than we do benefit.
I always tell my patients the best treatment is no treatment.
Dr. Treon.
Tom, I just want to remind everybody that even Jan Waldenstrom used to say, let well do. If a patient is doing well, really don't introduce therapy and potentially toxicity. But I think the questioner here is asking a genuinely good question. In the past, we've been reluctant to start therapy because the toxicity of many of the drugs, both short-term and long-term, were things that we weighed into account. And, and many times, we would wait until the patient genuinely needed, therapy. They were symptomatic. We didn't let the patient fall off the cliff before we lended, a helping hand. But now, as you're seeing these drugs that are right on target, they're affecting the key signaling pathways that keep these cells, growing and alive, this is an area and a room for study. And we should, take this on as a challenge, I think, but you do it in a clinical trial to see whether or not some of the endpoints that Steve Ansell raised, can be addressed. But the only way to really, get at the heart of this is to do a very thoughtful clinical trial. And now we have drugs and the means to be able to do those trials.
All right, let's go to the next question. Since we are all immunocompromised to some degree, do you have thoughts regarding having an in-person ed forum next year? And I guess that includes, should we make them show their COVID card? Any thought? I mean, anybody want to talk on that? I think we just have to kind of see where we go. All right.
I think we're all saying that's up to you, Tom.
That's right. I was about to say, it's about from the board.
Yeah, the board, not me. All right.
But I just, if I can add one quick thing, I had my hand up at the end of the last question.
Oh, I'm sorry. I missed you.
I thought there was some great comments. And one more thing to add about potentially treating earlier is if we really have prognostic information that someone is going to progress in a very short time, and that's the exact population we would focus a trial on. And especially, if we have the potential for a cure, but also if someone has the chance of a bad consequence in the near future, that would probably be the first step.
That is a great point. And the reason, we do have now a prognostic score that we have developed for patients with asymptomatic disease, and we actually are able to identify a small, but I think significant group of patients who are at immediate risk of becoming, of needing therapy within a couple of years, for example. And then I think that ultra high risk population might be, a population that we could potentially look into. But again, we have to be a collaborative, multi-center, multinational study to make it as powerful as possible.
And remember how difficult it is in CLL, in chronic lymphocytic leukemia. Even when you have a p53 mutation, you do watch and wait, and you don't start immediately when the patient is doing fine. So it's a very important question, but very tough to answer.
I agree. All right, next question. Do you have any statistics regarding patients with multiple non-melanoma skin cancers which could have a causal relationship to non-Hodgkin's lymphoma, demyelinating peripheral neuropathy, and Waldenstrom?
No.
I know that lymphoma does have a lot of people that has skin, but lesions, but I'm not sure we do. Yes, Dr. Treon.
Yeah, Tom, some years ago, we did publish a study that looked at 1,000 consecutive Waldenstrom patients. And what was notable was the high incidence of skin cancers, both the melanoma as well as non-melanoma. So I do think there's an interesting relationship. There was one triad we did identify. It was in older males, where that triad included Waldenstrom's, prostate cancer, as well as skin cancer. So we did see this redundantly within the same patient. So I do think it is really important, for our patient population to make sure they get frequent skin checks, and for men to also make sure they're on top of their PSA screening and, getting a digital exam as well for prostate CA.
Okay, next question. This question is about CD20s other than rituximab, and if they are approved and being used for Waldenstrom for biosimilars, second generation antibodies, I guess IV and subcutaneous, or is rituxan still the main drug to use? Is everybody still you, Dr. Buske?
I think There was a time window for testing obinutuzumab in indolent B-cell lymphomas, and this time window was used in chronic lymphocytic leukemia, follicular lymphoma, a little bit in marginal, but actually not so much in Waldenstrom. I think this time window is closed, so I think there will be no clinical trials anymore being pushed forward to test the efficacy of obinutuzumab in Waldenstrom. And also we have to take into account that we have so strong other drugs. They are so strong that probably the minor difference between obinutuzumab and rituximab is actually overcompensated by drugs such as venetoclax or ibrutinib. So I think rituximab will stay the standard anti-CD20 antibody in Waldenstrom. The biosimilars are used to a very large proportion in Germany and Europe. I don't know, I think it's the same in the US. But the rituximab biosimilar part counts up to 60-70%. In the UK, up to 90% of all rituximab. So I think for us, it's the same. Ofatumumab is actually not used at all, I would say, in Europe, does not play any role. I think we have to distinguish these, let's say, conventional anti-CD20 antibodies now from the bispecifics. They are something completely different, which we discussed before.
All right, Dr. Treon.
Yeah, just one thing to add. Years ago, I had the privilege of chairing the Rituxan investigator meetings, and it really brought together, this great brain trust of folks involved with Rituxan study. And as I remember, Steve Ansell, Steve, that may have been actually the first time that we actually got to meet during those meetings. But I think everyone agreed at that point that the bar, set was very high. I mean, we saw Rituxan activity at such high levels that, dreaming about the next generation of drugs, would be very difficult. Now, there are some, hints as to why a drug like obinutuzumab may be better in select populations of patients. We all react differently to Rituxan based on our genomics. In fact, the receptor that we express can be very different, between individuals. And this is where, the thought was that by creating obinutuzumab, you were actually creating a molecule that could better interact with those receptors, regardless of your underlying genomics. But there is a trade-off here. With obinutuzumab, we also do see more, side effects when you're infusing the drug. And so this is going to be a trade-off, in terms of giving, another CD20 antibody against Rituxan that we've all become, very, very familiar with. The one last thing I just want to say about ofatumumab, this has been a godsend when you have somebody who has infusion reactions to rituximab. And one of the things that we've noticed, and Hori published a very nice paper on this, is that there is a small population of Waldenstrom patients who become allergic to the drug with repeated usage. And this is one circumstance we're using ofatumumab, which is a humanized antibody. It doesn't contain the part mouse protein that you see in Rituxan. You can use this successfully in a vast majority of cases when somebody has developed an allergy to rituximab.
All right, I guess, thank you. The next question has multiple questions with it. The phase 3 Aspen trial in Waldenstrom, when compared zanubrutinib to ibrutinib, generally showed a better toxicity profile for zanubrutinib. One notable exception was the neutropenia issue. Do you know what the biological explanation for this might be? Was it a temporary side effect for patients at the start of the trial, or was it constant throughout? Did it return? If it is a temporary side effect, would Neulasta or Neupogen be helpful for these patients?
Yeah, I think I can answer that question. I think the neutropenia might have to do with the more direct or more specific BTK inhibition that is seen with zanubrutinib compared to ibrutinib. My sense is most of the neutropenias were grade 1 and grade 2s, which means they were very mild and moderate neutropenias in which really no intervention was necessary. On the higher grade toxicities, the use of Neulasta or Neupogen was allowed by the investigators or their, if they felt it was necessary at the time, so that those medications can be used to sustain patients if they were to develop neutropenia on these treatments. I do not get a sense that is something that is temporary. I think that's something that kind of is going to be more chronic with the use of zanubrutinib. Having said all that, my personal experience using this medication, I have seen some neutropenia, but I really have not needed to use a lot of Neupogen or Neulasta on these patients.
Okay, Dr. Treon.
Just unmute myself here. I think it's very interesting when you look at the phase 2 data from zanubrutinib. This was in the paper that was published by Judy Trotman in Blood. In the early development of zanubrutinib, they were actually looking at once daily dosing as well as twice daily dosing. So the once daily was 320 milligrams, and the twice daily was 160 milligrams, but given twice a day. So the same amount of total drug, except given once a day or split up over 2 doses. And curiously, the rate of neutropenia with once a day dosing was actually less. There was some hit in the efficacy, and I think this is why the company at that point prioritized twice daily as opposed to once daily. But I do think, there is this option of being able to give the drug once daily. The other observation I just think it's also important for us to think about is the Aspen trial, was a Waldenstrom's trial. It pitted ibrutinib versus zanubrutinib, and there were actually more cases of even grade 3 neutropenia. But when you look at the Alpine trial, which was in CLL patients, again, the same kind of trial design, zanubrutinib versus ibrutinib, that difference with neutropenia was far less notable. And I think that was actually quite interesting, to take into account that the Waldenstrom's disease itself may be also part of the reason why we're seeing this neutropenia. And it may not be, the drug per se, but keep this in mind, because I do think, the disease state also plays a role in terms of, the propensity for neutropenia that may be less dependent on the drug itself.
All right. Thank you, Dr. Treon. Next question. What is the mechanism through which ibrutinib and rituximab impede COVID vaccine antibody response? Dr. Ansell, I see you.
So I think there are actually a variety of different mechanisms. Dr. Treon was already touching a little bit on some of the things with zanubrutinib and ibrutinib and the mechanisms. They also have an effect on cytokines and do a lot of things that make immune cells active and function. But I think if we wanted to say ibrutinib, which basically inhibits B cells and their growth and function, and rituximab, which specifically depletes B cells, are the two main ways in which you can have a B cell population that typically gets activated, turns into a plasma cell, and makes antibodies as part of its natural behavior. If you're messing with the ability of cells to function, or you're depleting them out of the mix, that really makes it difficult or more difficult for your immune system to make the kind of response that you need when you have an antibody stimulus or you have a vaccine. So, there are many ways you could answer that question, and some of them can get quite technical, but I think in essence, you're hamstringing the machinery that you need to make an antibody.
Dr. Branagan.
Great explanation, Dr. Ansell. And I just want to add that another difference is how long-lasting Rituxan is. So, this goes right to the bone marrow and stays for months. So that effect of that Rituxan can deplete B cells for up to a year, maybe even more, as opposed to ibrutinib. It's more of a constant mechanism from taking it daily that would we think will end when you actually stop the drug.
Thank you, both of you. Next question. Does IgG levels increase with treatment for Waldenstrom, and why? Dr. Castillo.
our experience has been that pretty much with every treatment given to patients with Waldenstrom's, the IgG does decrease. Actually, in a number of our patients, the IgG is already low even before we start any treatment. I would say in a treatment-naive population, patients who have never been treated, probably anywhere between 40 and 50% of patients already have low IgG levels. And when we treat them, most of these patients will have even further decrease in IgG levels. We see probably a higher decrease with patients treated with chemotherapy and anti-CD20 antibodies and protease inhibitors, maybe a little less with BTK inhibitors, but we still see some minor decreases there. And those levels typically do not come back up. We have had a handful of people in whom those IgG levels have recovered, but that is not the expectation to be had. Most of these patients remain with low IgG levels.
All right. Thank you, Dr. Castillo. Next question, what future drug combinations do you think are most promising for long-term management of Waldenstrom? Any thoughts on the Dr. Treon?
Yeah, I would just like to make a plug that I think, we're seeing a very exciting time for Waldenstrom's that's really allowing us to use the genomics to help drive, drug therapy. And for this, I think all of us, who are on this call today, should be very inspired. There's a lot of reason to be optimistic about the trial that Hori is currently running, combining venetoclax along with ibrutinib. I think we're going to be seeing a similar trial also with zanubrutinib emerging very soon. And this has to do with the fact that venetoclax can knock down the defense mechanisms that are often put up by the cell to protect it against a BTK inhibitor. So I think this kind of synergy that we've seen has played out already in other diseases like CLL and mantle cell lymphoma may very well, also be important to Waldenstrom's. But at the end of the day, both are very, very good drugs, very, very active. So we're going to have to see, what that additional benefit is to combining both of these drugs, and also to look at the potential side effects that may come. The other trial that I think, inspires me as we look to the future is the ulocuplimab trial that was just published in the journal Blood, combining it with ibrutinib in patients that had the CXCR4 mutation. I think this trial showed us that we can target the second most common mutation in Waldenstrom's, that being CXCR4. And as many of you know, now there is this trial with movarexafor, which is an oral antagonist, an oral blocker of CXCR4, that's being run both in North America as well as in Europe. But these are just examples of how we've been able to use, the lessons learned from the genome to help drive, drug therapy. And we'll continue to be able to, use this playbook for other combinations to come.
I would like to add that there are so many other combinations, not only in the United States, but also outside of the United States. In Germany, for example, there are a lot of BTK combinations with protease inhibitors that I think is going to be a very interesting issue. There's another study with the Mayo Clinic using ixazomib and adding daratumumab as well to ibrutinib. There's going to be a triplet coming up as well, ibrutinib, venetoclax, and rituximab at some point. So, I think some of these studies are actually looking into fixed duration treatments. I think that is the idea, trying to give treatments that are very effective, chemo-free, but with a short duration of therapy. So in that way, patients don't have to be on therapy indefinitely. So I think all this is a new cadre of generation of clinical trials in patients with Waldenstrom's.
And to add, I think we already mentioned the bispecifics. Who knows? Perhaps the bispecifics will go over the threshold, and we will have for the first time CRs in this disease. So I think it's exciting times. It's a moving field, let's see whether double or triple combinations help us to approach at least our goal to eradicate or to nearly eradicate the disease.
Thank you. Dr. Ansell, let's go to the next question. A patient is wanting to know if you're developing a Waldenstrom clinic.
So the answer is yes, we do, and we actually have one. It's not that we're developing one. We kind of specifically have a number of team members that are very focused on Waldenstrom's, very similar to what Dana-Farber and their group is doing, and we have a number of researchers that are very focused around research related to Waldenstrom's. And I would make a case that although that's true at Mayo, I think we're blessed with all the folks on this call and their different teams around the world that are doing things similarly. So the goal is really to have these pockets of excellence, but I think one of the things that's happening more and more, which is really exciting, is collaboration between these teams. And again, I think as we move forward, the goal is always to see more patients cured of Waldenstrom's overall.
Thank you. Next question. When Waldenstrom relapses in general, how quickly can the disease progress?
So maybe seeing my mic was unmuted, I'll take the question first, but I think there are a few things that are important to note. Is that why did it relapse? And there's obviously people that are not being treated and being watched, and their disease is slowly progressing, and treatment is necessary. That may be a very slow and indolent process. There may be people who are on therapy, and we spoke about BTK inhibitors and resistance, where that may be a lot quicker, or they stop the drug and then very quickly things can happen, or there is evidence for transformation to a more aggressive disease, and that actually really makes for a much more dramatic change. So this is a question where you have to hedge your answer a little bit to say it really depends on what is making the disease progress, because it can be quite different.
Okay, thank you, Dr. Ansell. So that was our last question. Does anybody have anything they would like to say at the end? Or we can just move on. I want to appreciate all of the doctors on the forum. They obviously know a lot, in fact, everything about Waldenstrom, and we appreciate them doing this for us. It's a great help. And I also appreciate all the people who sent in the questions. And we will now sign off and get ready to listen to Dr. Glenn Nichols. Thank you, guys.
Thanks.
Thank you, everybody.
Thank you.
Thank you.